Welcome back to Abdominal Assessment. All right, so now we're getting into the abdomen, and here's what we're learning about today. So as we move into the abdominal assessment, it's going to be really important that you start building a mental picture of where these organs are located in the body. And understanding anatomy is what's going to help us connect assessment findings, pain, and symptoms to what might actually be happening with the patient. So on the left side of the slide are the major GI organs, and you can see the digestive tract starts at the mouth, moves through the pharynx and esophagus into the stomach, small intestine, and large intestine, and then ends at the rectum and anus. And you also see the accessory organs like the liver, gallbladder, pancreas, salivary glands, which all help with digestion even though food doesn't physically pass through them, or it shouldn't at least. So as nurses, knowing where these organs are helps us interpret findings during assessment. For example, if a patient tells you they have right upper quadrant pain, you should immediately start thinking about those organs that are located there, like the liver or gallbladder. If someone has right lower quadrant pain, maybe you're thinking about appendicitis. Epigastric pain may point more towards the stomach or the pancreas. So this is where anatomy starts connecting directly to clinical judgment. Now, on the right side of the slide are the GU organs, the genitourinary, including the kidneys, ureters, bladder, and urethra. And one thing I want you to remember is that the kidneys are retroperitoneal, meaning they sit farther back behind the abdominal cavity. And because of that, kidney pain is often felt more in the flank or back area instead of the front abdomen. You'll also notice how closely these organs relate to major blood vessels like the aorta and inferior vena cava. And that becomes important later when we talk about things like abdominal aortic aneurysms or assessing circulation to organs. So as we go through abdominal assessment, this anatomy helps guide everything that we do, where we auscultate bowel sounds, where we palpate for tenderness or masses, how we identify distension, how we document findings accurately, and how we recognize when something may be abnormal or urgent. So I encourage you to start kind of visualizing these organs underneath the surface of the abdomen, because that's what helps assessments become more meaningful instead of just kind of memorizing steps. The slide shows the reference lines we use to divide the abdomen into sections, and these sections help us communicate findings clearly and consistently with other healthcare providers. So instead of saying the patient has pain somewhere on the right side, we can be much more specific about exactly where the finding is located. So the image on the left shows the four abdominal quadrants, which is the system you'll probably use most often in clinical practice. The abdomen is divided into right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. And you'll use these quadrants constantly when you're documenting pain, tenderness, bowel sounds, distension, or masses in your abdominal assessment. So, for example, if a patient reports right upper quadrant pain, we start thinking about those organs that are located there, like the liver or gallbladder, whereas right lower quadrant pain may make us more think about appendicitis. So again, we're connecting the anatomy from the previous slide to these quadrants. The image on the right shows the 9-region system, which is more detailed. The system is often used when describing more specific findings or locations, and you'll see regions such as epigastric, umbilical, hypogastric, or suprapubic, right and left inguinal regions. So epigastric pain may be associated with gastric reflux, ulcers, or pancreatitis, whereas suprapubic pain may more point towards bladder issues, and pain in the right inguinal region could relate to appendicitis or a hernia. So the reference lines are really there to help us communicate accurately with providers. They're also there to trend changes in our patient's symptoms, document our findings clearly, and prioritize possible complications based on the location of pain or tenderness. So this slide gives us an overview of the major structures we assess when we perform an abdominal assessment. Even though we often think of the abdomen as mainly the digestive system, there are actually multiple body systems and structures located here that can contribute to symptoms or abnormal findings. So first, we have the gastrointestinal organs. These include the stomach, small intestine, and colon. These organs are responsible for digestion, absorption of nutrients, and elimination of waste. So when patients complain about symptoms like nausea, vomiting, diarrhea, constipation, bloating, or abdominal pain, these are often the organs we're thinking about first. You'll also see the accessory organs listed here, so the liver, pancreas, and gallbladder. So again, even though food doesn't pass directly through these organs, they do play a major role in digestion. So the liver helps with metabolism, detoxification, bile production, so much more. We'll get into when we talk about adult health too. The gallbladder stores and releases bile. The pancreas produces digestive enzymes and also helps regulate blood glucose. So when these organs become inflamed or diseased, patients can present with very different symptoms. For example, gallbladder issues may cause right upper quadrant pain after eating fatty foods. Pancreatitis often causes severe epigastric pain that radiates to the back. Liver disease may lead to jaundice, ascites, or enlarged abdominal veins. Next are the GU organs, including the kidneys, ureters, and bladder. And sometimes patients will come in with abdominal pain that is actually urinary in origin rather than GI related. Things like kidney stones, urinary retention, UTIs, or bladder distension. These can all present with abdominal or flank discomfort. And we also can't forget about the blood vessels, peritoneum, and muscles of the abdomen. The abdominal aorta, it's a major vessel that we assess, especially in older adults or patients with cardiovascular risk factors. So an enlarged or widened aorta can indicate an abdominal aortic aneurysm, and that can become life-threatening. The peritoneum is another important structure, and when the peritoneum becomes inflamed, patients may develop guarding, rigidity, rebound tenderness, or severe pain. And these findings should immediately raise concern. So as we go through abdominal assessment, I want you to remember that not all abdominal pain comes from the same system, and part of your job as a nurse is using assessment findings, anatomy, and patient symptoms together to think critically about what could be causing the problem. Now let's talk about what's actually happening during ingestion and digestion, because understanding normal physiology helps you recognize when something is going wrong. Digestion is really a combination of both mechanical and chemical processes. Mechanical digestion is the physical breakdown of food. This includes chewing, swallowing, peristalsis, and the churning movement that occurs in the stomach and intestines. Peristalsis is especially important to understand because it's those wave-like muscular contractions that move food into the GI tract. And when peristalsis slows down or stops, patients can develop constipation, bowel obstruction, or decreased bowel sounds. When it speeds up too much, patients may experience diarrhea or cramping. Chemical digestion is the breakdown of food substances like hydrochloric acid, enzymes, and hormones. And these chemical reactions help convert food into nutrients that the body can absorb and use for energy. The digestive process actually begins in the mouth, and as food is chewed or masticated, it mixes with saliva. Saliva starts the digestive process early by helping break down those carbohydrates. And the food then forms into a bolus, which is basically a soft mass of chewed food ready to be swallowed. The bolus moves through the oropharynx and esophagus, is pushed towards the stomach through slow peristaltic movements. Once it reaches the stomach, it mixes with those digestive juices and hydrochloric acid. The stomach churns and breaks the food down even further until it becomes a semi-liquid substance called chyme. And I want you to think about how all of this connects to symptoms patients might report. For example, difficulty swallowing may point to esophageal issues, heartburn or reflux that can occur when stomach acid moves upward. Nausea and vomiting, it may indicate irritation or slowed gastric emptying. Hyperactive bowel sounds may suggest increased GI motility, while absent bowel sounds could indicate a serious obstruction or an ileus. So as nurses, understanding the normal digestive process helps us interpret what we're hearing, seeing, and palpating during assessment. So when you know how the system is supposed to work, it becomes so much easier to recognize abnormal findings and then connect them to possible causes. Now that we've talked about digestion, let's look at what happens next, absorption of nutrients. This is really the whole purpose of digestion. The body is trying to break down into forms that we can actually use to absorb for energy, growth, and normal body function. Most nutrient absorption occurs in the small intestine. Even though the stomach gets a lot of attention, its primary role is more about mixing and breaking food down. The small intestine is where the majority of absorption actually takes place. So the first section of the small intestine is the duodenum. This is where pancreatic juices and bile enter and mix with the chyme coming from the stomach. Pancreatic enzymes help break down proteins, fats, and carbohydrates. Bile, which is produced by the liver and stored in the gallbladder, helps emulsify fats so that they can be absorbed more easily. This is why problems with the pancreas, liver, or gallbladder can significantly affect digestion and nutrition. Patients with gallbladder disease or pancreatitis may have trouble digesting fatty foods, and they can develop nausea, bloating, or malabsorption issues. So as chyme continues through the jejunum and ileum, nutrients continue to be absorbed into the bloodstream. This includes things like glucose, amino acids, vitamins, minerals, water, and electrolytes. I want you to think about how this connects to our assessment findings. So if nutrient absorption is going to be impaired, patients may present with weight loss, malnutrition, weakness or fatigue, vitamin deficiencies, diarrhea or fatty stools, even electrolyte imbalances. That can all manifest in different ways. For example, patients with inflammatory bowel disease, like Crohn's disease, they may have impaired absorption because their intestinal lining becomes damaged and inflamed. And as nurses, understanding where absorption occurs helps us connect those GI disorders to the symptoms that we're seeing clinically. It also helps explain why some patients become dehydrated or malnourished even when they appear to be eating normally. Now let's talk about elimination, which is the final step in the digestive process. And after nutrients have been absorbed in the small intestine, any remaining material moves into the large intestine. And the large intestine's main job is not digestion. It's mainly responsible for absorbing some remaining water and electrolytes and then preparing waste for elimination. This is really important because the body is constantly trying to maintain that fluid and electrolyte balance. And as waste moves through the colon, more water is absorbed. If too much water is absorbed, stool becomes hard and dry, leading to constipation. If not enough water is absorbed, stool becomes loose or watery, which results in diarrhea. And eventually the remaining waste products are excreted as feces, and under normal conditions, waste products from ingested food are typically eliminated within about 48 hours, although this can vary from person to person depending on their diet, hydration, activity level, medications, and kind of their overall health. So start thinking about the elimination process as an important assessment area, not just a routine bodily function, because changes in bowel habits can tell us a lot about what's happening physiologically. For example, constipation may occur with dehydration, opioid use, decreased mobility, or bowel obstruction. Diarrhea, this we know, can lead to dehydration and electrolyte imbalances very quickly. Black tarry stools, this can indicate an upper GI bleed, whereas bright red stool could suggest lower GI bleeding or even hemorrhoids. Pencil thin stools, could raise concern for an obstruction or even colorectal cancer. So bowel assessment is a major part of our patient's care, and you'll frequently assess bowel patterns, stool appearance, presence of blood, abdominal distension, bowel sounds, patient's comfort and pain. It's also important to remember that many patients are uncomfortable talking about bowel habits. So creating a professional and non-judgmental environment, it's going to be really important during your assessment. And understanding normal elimination helps you recognize when findings become abnormal or potentially life-threatening. So when we assess older adults, it's important to remember that, again, normal aging causes changes throughout the GI system and every system that we've talked about. And those can affect nutrition, digestion, elimination, and even how symptoms present. So one of the first changes we see is reduced production of saliva and stomach acid. Saliva is important, remember, for lubrication and the beginning stages of digestion. So decreased saliva can make chewing and swallowing more difficult. Reduction of stomach acid, it can also affect digestion and the absorption of certain nutrients like vitamin B12, calcium, and iron. Older adults may also experience more difficulty with swallowing, digestion, and absorption overall, and this can increase the risk for malnutrition, dehydration, and unintended weight loss, especially if the patient already has chronic illness or mobility limitations. And then motility and peristalsis, this also slows down with age. And remember, peristalsis is that movement that pushes food through the GI tract. So when this slows, constipation becomes more common. This is why constipation is such a major issue in older adults, especially when combined with decreased mobility, lower fluid intake, or medications like opioids. Changes in dentition, that's another important consideration. Older adults may have missing teeth, dentures, gum disease, or chewing difficulties, and these issues can affect food choices and nutritional intake. Sometimes patients avoid healthier foods simply because they're really difficult to chew. One really important point on the slide is that older adults may be less likely to feel pain with abdominal conditions. They can have serious infections or abdominal emergencies with really subtle symptoms. For example, an older adult with appendicitis, bowel obstruction, or peritonitis may not present with the classic severe abdominal pain we would expect in a younger patient. You may also notice there is changes in body composition, such as increased fat accumulation in the lower abdomen. In addition, overall organ function declines with age, including liver and kidney function, which can affect metabolism, medication clearance, and healing. So this means we need to be especially thorough when we're assessing older adults. Sometimes their symptoms are going to be really vague or atypical. So instead of those dramatic findings, you may notice things like fatigue, decreased appetite, confusion, weakness, functional decline, mild abdominal discomfort instead of severe pain. So this is why our older adults are going to require really strong clinical judgment. We can't rely on those textbook symptoms. We really have to look at the whole patient and recognize subtle changes that may indicate something more serious. So this slide is going to highlight important culture variations and health disparities. So as nurses, we need to recognize that certain health conditions may occur more frequently in specific populations, but we also have to be careful not to stereotype or make assumptions about patients. So every patient is an individual, and culturally competent care means that we're approaching each person respectfully and without bias. So some conditions have known genetic or population-based prevalence patterns. For example, sickle cell anemia. This is more commonly seen in individuals with African ancestry. It also could be European. G6PD deficiency may occur more frequently in individuals of Africa, Mediterranean, or Asian descent. Lactose intolerance. This is more common in many Asian, African, Hispanic, and indigenous populations. So understanding these patterns can help guide our assessment and clinical reasoning, but it shouldn't really replace individualized patient care. The slide also highlights conditions like chronic liver disease, liver and bowel cancer, obesity, diabetes, and end-stage renal disease. These are conditions that are influenced by many factors, including access to care, socioeconomic status, nutrition and food access, environmental exposures, education, insurance coverage, and experiences with healthcare systems. Health disparities, they're not simply about genetics, they're often connected to broader social determinants of health. So you'll see things like Helicobacter pylori, H. pylori, wow, I can't ever say it, infection. This bacteria is associated with gastritis and peptic ulcer disease, and it occurs more commonly in some populations and areas with limited healthcare access or crowded living conditions. So we need to think beyond the diagnosis. We should ask ourselves, does this patient have access to healthy food? Can they afford medications? Do they have transportation to appointments? Are there language barriers affecting communication? Are cultural beliefs influencing healthcare decisions? Because we want to be culturally competent nurses. We want to avoid assumptions, respect their beliefs and practices, and really listen to our patients. This slide focuses on priority or urgent abdominal assessment findings, so in other words, symptoms that may indicate something serious or potentially life-threatening and require our immediate attention. So one of our biggest responsibilities is recognizing when a patient is unstable or when symptoms could indicate an emergency. So abdominal complaints can sometimes seem vague at first, but certain findings should really immediately raise your concern. So one of those is severe dehydration, especially when patients are experiencing persistent nausea, vomiting, or diarrhea. These symptoms can quickly lead to fluid volume deficits and electrolyte imbalances. So patients may present with tachycardia, hypotension, dry mucous membranes, decreased urine output, weakness, or dizziness. And in severe cases, dehydration can progress to shock, especially in our older adults or even young children. Fever is going to be another important finding because it may indicate infection or inflammation. So when fever is combined with abdominal pain, we start thinking about possibilities like appendicitis, cholecystitis, diverticulitis, pancreatitis, or peritonitis, all the itises. Acute abdominal pain, this is something we take very seriously. Anything sudden, severe pain can indicate conditions like bowel obstruction, perforation, ischemia, ectopic pregnancy, or appendicitis. One thing I want you to remember is that the severity, location, onset, and associated symptoms are going to all help guide our clinical judgment. One of the most concerning findings on this slide is a board-like abdomen. So this refers to extreme abdominal rigidity, where the abdomen feels very hard and tense during our assessment. This can indicate peritoneal irritation or peritonitis, which is a medical emergency. So patients with peritonitis may also have rebound tenderness, guarding, fever, nausea, and severe pain with movement. So this is where our assessment skills become really critical. We are often the first people to recognize when a patient's condition is deteriorating. So when we're assessing a patient with urgent abdominal findings, you should also pay attention to their vital signs, mental status changes, skin color and perfusion, any signs of shock, changes in bowel sounds, and the degree of abdominal distension or rigidity. Again, I also want you to remember that not every patient presents textbook. We have those older adults, immunocompromised patients, or patients with chronic illness. They could present with subtle findings even when something is really serious. So now we're moving into subjective data collection, which is a huge part of the abdominal assessment. Before we ever touch the patient, we're going to gather a thorough health history, and a lot of times the patient's answers will already start pointing you toward what may be going on. So the first thing we assess is risk factors and past medical history. So previous GI or GU conditions that these can significantly affect our assessment findings. For example, a patient may present with a history of GERD, acid reflux, Crohn's disease, gallstones, liver disease, kidney stones, or abdominal surgeries. They may already be at higher risk for certain complications or reoccurrent symptoms with that kind of history. Hold on, I need a drink. Okay. Lifestyle and personal habits are also really important to assess. We want to ask about things like chewing or swallowing difficulties, appetite changes, weight gain or weight loss, bowel and bladder habits, any alcohol use, substance use, and their dietary habits. These questions are going to feel very personal to patients sometimes, but it's important to ask them in, again, a professional and non-judgmental way. You'll also notice the slide connects abdominal assessment to other body systems. GI and GU problems can affect multiple areas of the body. For example, liver disease may cause skin changes like jaundice. GI bleeding can affect the hematologic system and lead to anemia. Kidney dysfunction, this can affect fluid balance and neurological status. We also want to ask about occupations, which can provide important clues. Patients who work around chemicals, toxins, or infectious exposures may have increased risks for certain GI or liver conditions. Any foreign travel, that's another important question because it can expose our patients to different types of infections, parasites, contaminated food, or waterborne illness, like hepatitis. We also assess for high-risk behaviors. This may include things like unprotected sex, IV drug use, excessive alcohol use, because these behaviors can increase the risk for conditions like liver disease, certain infections, and again, hepatitis. So medication history is going to be next. It's going to be extremely important in our abdominal assessment because many medications can affect the GI system. For example, NSAIDs, these can contribute to ulcers or GI bleeding. Opioids, these can cause constipation. Antibiotics could lead to diarrhea or C. difficile infection. And finally, family history matters because many GI and GU disorders have genetic components. So a family history of colon cancer, inflammatory bowel disease, liver disease, or kidney disease may increase a patient's risk. So again, subjective data collection, this is going to be where we begin building our clinical picture. The questions are going to help guide what you focus on during your physical assessment and what findings may require further investigation. This slide continues our discussion of that subjective data collection, and it's going to focus on patient teaching, health promotion, and common symptoms related to GI system. So assessment is not just about identifying problems, it's also about prevention and education. So a big part of our nursing care is helping patients reduce their risk factors and recognize symptoms early. And one important area of health promotion is colorectal cancer screening. Colorectal cancer is one of the most preventable cancers when screening is done regularly, and patients may need education about colonoscopies, stool testing, diet, and recognizing warning signs such as changes in bowel habits or blood in the stool. Foodborne illness, this is another important teaching topic. Patients can develop GI infections from contaminated food or water, undercooked food. So teaching often includes proper hand hygiene, food preparation, cooking temperatures, and then safe food storage, which many people actually don't know about. So that's where you come in. We also educate patients about hepatitis A, B, and C. These infections affect the liver and are transmitted in different ways. A is often spread through contaminated food or water. If it's a bowel, it comes from the bowel. Whereas hepatitis B and C, these are spread through blood and body fluids. So teaching may include vaccination, safe food handling, avoiding needle sharing, and safe sexual practices. So the second half of this slide focuses on common GI symptoms where you'll assess frequently in practice. Things like indigestion or dyspepsia. These can include symptoms like bloating, discomfort, reflux, or a feeling of fullness. Sometimes this may be relatively minor, but persistent indigestion can also indicate ulcers, acid reflux, sometimes even cardiac issues in some patients like heart attack. Anorexia means loss of appetite. This can occur with infection, cancer, depression, GI disorders, or chronic illness. In older adults, especially, decreased appetite can quickly contribute to malnutrition and weakness. Nausea and vomiting, very common symptoms, but they can have many different causes. So when assessing vomiting, we want to ask questions like, how long has it been occurring? What does the vomit look like? Is there blood present? Are there associated symptoms like pain or fever? Hematemesis, meaning vomiting blood, and so this is always concerning. Patients may describe bright red blood or vomit that looks like coffee grounds, which can indicate upper GI bleeding. Abdominal pain, this is another major symptom we assess. One thing I really want you to focus on is asking that detailed follow-up question. We want to know location, severity, onset, duration, what makes it better, what makes it worse, any associated symptoms. Remember that the patient's history is often going to give us some of the biggest clues about what may be happening. So the more thorough your subjective assessment is, the stronger your clinical judgment will become. This slide continues some of the common symptoms you'll assess during abdominal and GI history collection. Many of these symptoms may seem really simple at first, but they can point to significant underlying conditions. So always asking good follow-up questions is really important. First, we have dysphagia, which means difficulty swallowing, odinophagia, which means painful swallowing. Patients may describe food as getting stuck, coughing when eating, or pain with swallowing. So these symptoms can occur with GERD, so that acid reflux, esophageal strictures, neurologic disorders like stroke, or even esophageal cancer. Dysphagia is especially important because it increases aspiration risk, which can lead to pneumonia, which is something we don't want because people die from pneumonia. Next are changes in bowel function, including constipation and diarrhea. So one thing I want you to remember is that we always want to compare bowel habits to what is normal for that specific patient. Constipation may be related to decreased mobility, low fiber intake, dehydration, opioid use, bowel obstruction. And then diarrhea can result from infection, food intolerance, inflammatory bowel disease, medications, or malabsorption disorders. Persistent diarrhea is going to be concerning because, again, it can quickly lead to dehydration and electrolyte imbalances. Jaundice, also called icterus, refers to yellowing of the skin or sclera caused by elevated bilirubin levels. So this finding often points towards liver dysfunction, bile duct obstruction, or hemolysis, so destruction of red blood cells. When we're assessing jaundice, you'll want to think about associated symptoms like, are they having any dark urine, pale stools, itching, or fatigue? We also talk about in this slide urinary and renal symptoms because abdominal assessment overlaps closely with the GU system. So patients may report urinary incontinence, flank pain, difficulty urinating, renal colic, which is severe pain often associated with kidney stones, flank pain. This is especially important because patients often mistake kidney pain for back pain. And finally, remember that older adults are going to present differently than younger patients. Again, those vague symptoms, delayed symptom reporting, minimal pain, even when it's serious. So you could see things like confusion, weakness, decreased appetite, functional decline instead of those classic GI symptoms. So now we're moving into the actual physical assessment techniques for the abdomen. There are 4 techniques you already know from other assessments: inspection, auscultation, percussion, and palpation. But the abdomen is unique because the order is different than what you've probably learned. Well, I know that you've learned in the past. So for most assessments, we usually inspect, palpate, percuss, and then auscultate. But for the abdomen, the correct order is inspection, auscultation, percussion, and palpation. And the reason for this is that palpation and percussion can actually change bowel sounds. So if we touch or stimulate the abdomen first, we may alter what we hear during auscultation, and we may get inaccurate findings. So first, we inspect before touching the patient at all. We look at the abdomen for the contour, symmetry, any distension, skin changes or scars, any visible masses or pulsations, and movement with respiration. Inspection starts the moment you walk into the room. Remember, with your eyes, you're already observing how the patient moves, if they're guarding, breathing, or responding to discomfort. So next is going to come auscultation. We listen for bowel sounds in all 4 quadrants. Before touching the abdomen, we're assessing presence or absence of bowel sounds, frequency, and then the character of the sounds. You may hear normal active bowel sounds. You might hear hyperactive bowel sounds or hypoactive bowel sounds, even nothing, so absent bowel sounds. And remember, absent bowel sounds can indicate something serious. So that's not something we really want to hear, is nothing. So definitely gonna, dive deeper into that. So after auscultation comes percussion. Percussion helps us assess what's underneath the abdominal surface. We're listening for tympany, which is a drum-like sound over air-filled structures, any dullness, which may indicate solid organs, masses, or fluid. Percussion can help identify things like enlarged organs, ascites, or abnormal masses. And finally, we palpate, and palpation allows us to assess tenderness, masses, muscle guarding, organ enlargement, temperature, and texture. We also start with light palpation before moving to deep palpation, and we save any painful area for last so we don't increase guarding or patient discomfort early in the exam. And then always thinking about patient comfort. So warm hands, clear communication, watching the patient's facial expressions as we're palpating. Patients will often tense their abdomen when they're anxious or uncomfortable, which can affect your findings. So this slide covers the basic equipment we'll need for our abdominal assessment. Most of this equipment you already use regularly, but each item has a specific purpose. The most important piece of equipment is going to be your stethoscope for the auscultation. Remember, auscultation comes before percussion and palpation. And we'll use the diaphragm of the stethoscope to assess bowel sounds and sometimes vascular sounds like bruits over the aorta or renal arteries. A measuring tape may be used if you need to assess abdominal girth. This is important for patients with ascites or abdominal distension, fluid retention, pregnancy, postoperative swelling. We're measuring the abdominal circumference over time to help us monitor for any changes. A pen or marker, this can be used to mark landmarks or measurement areas during certain assessments. Maybe we're doing abdominal girth daily, want to measure in the exact same location each time for accuracy. And finally, don't underestimate the importance of a pillow. Patients' positioning and comfort really matter a lot during abdominal assessment, so placing a pillow under the patient's knees can help relax the abdominal muscles and make palpation easier and more accurate. So before you begin the abdominal assessment, preparation is going to be really important. So good preparation helps us improve our patient's comfort and the accuracy of our assessment findings. So we want to make sure that the environment is warm, it's private, it's well lit. Patients are more likely to relax when they feel comfortable and respected. A cold room can cause muscle tension. Poor lighting may make it harder to observe things like skin changes, scars, distension, or pulsations. We also want the client to empty their bladder before the assessment because a full bladder can cause discomfort and may interfere with palpation findings, especially in the lower abdomen. Proper draping of the body is another really important part of the assessment. We want adequate exposure of the abdomen while still maintaining the patient's dignity and privacy. And remember, how we make patients feel during an assessment really matters just as much as the technical skill itself. So before starting, we're explaining the process, let them know what you'll be doing and why. This helps reduce anxiety. And as you assess, we're continuously observing the client for signs of discomfort or pain. Sometimes patients don't tell you verbally that they're uncomfortable, but you'll notice things like guarding, facial grimacing, muscle tension, holding their breath, pulling away during palpation. So these observations are part of your assessment too. So make sure you're paying attention. And finally, always examine painful areas last. If we start with the painful area first, the patient's going to be tense and their abdominal muscles guarding throughout the rest of the assessment, which makes your findings less accurate. So this slide gives an overview of the full abdominal physical assessment and how each assessment technique helps us gather different types of information. Remember, the abdominal assessment follows a specific order with inspection, auscultation, percussion, and palpation. Again, when we're observing the abdomen, we're looking at the contour and symmetry, skin color and integrity, scars or lesions, distension, visible masses or pulsation. Inspection also includes observing output like urine, emesis, and stool, which can provide huge clues about what's happening. Next comes auscultation. We listen to the bowel sounds in all 4 quadrants before touching the abdomen. We are assessing presence or absence of bowel sounds, the frequency and character. Then percussion to assess for areas filled with fluid, air, or solid tissue. We may percuss organs such as the liver, spleen, bladder, kidneys. And finally, we palpate. We always begin with light and then move to deeper. Remember, we're watching the patient's body language, their face, how they are tolerating the assessment. This slide just covers some additional abdominal assessment techniques that you may see in practice or perform when certain conditions are suspected. These are more focused or advanced assessment maneuvers that help us gather more information about possible underlying problems. First is the bladder scan. A bladder scan, this is a non-invasive ultrasound tool used to estimate how much urine is in the bladder. This is especially useful when we suspect urinary retention. Patients may complain of lower abdominal discomfort, difficulty urinating, or frequent small voids, and a bladder scan can help us determine whether the bladder is actually emptying properly. Next is the abdominal reflux. This neurological reflex is assessed by lightly stroking the abdomen and observing for contraction of the abdominal muscles, and changes in the reflex can sometimes indicate neurological dysfunction. You'll also see assessment techniques for ascites, which is fluid accumulation in the abdominal cavity, mainly from liver disease. 2 common tests are shifting dullness and fluid wave. These tests help identify excess fluid in the abdomen, which is often associated with liver disease, cirrhosis, heart failure, or cancer. Patients with ascites may also have abdominal distension, discomfort, shortness of breath, or weight gain. The Bloomberg sign refers to rebound tenderness, and this is used to assess for peritoneal irritation. This is done by pressing slowly into the abdomen and then quickly releasing pressure. Pain upon release is considered a positive finding, and a positive Bloomberg sign may indicate peritonitis or significant inflammation within the abdomen. It should always raise concern. Murphy sign, this is something used when we suspect gallbladder inflammation or cholecystitis. So during palpation of the right upper quadrant, the patient is asked to take a deep breath. If they suddenly stop inhaling because of pain, this is called inspiratory arrest, and it's considered a positive Murphy sign. The iliopsoas muscle test is associated with appendicitis. This test stretches the iliopsoas muscle. And pain with the maneuver may indicate irritation from an inflamed appendix, especially if the appendix is positioned behind the cecum. One thing I want you to remember is that these special tests are not usually routinely done on every patient. They're more focused assessments that are performed when your history and initial findings suggest a specific problem. And then this slide is going to bring everything together and focus on clinical decision making. So we know that assessment is not just about collecting information, it's about analyzing our findings, recognizing patterns, and deciding what actions need to happen next. So we use our assessment findings to help guide lab and diagnostic testing depending on the patient's symptoms and assessment findings. Providers may order testing such as blood tests to assess electrolytes, kidney function, liver function, maybe H. pylori breath test to check for a bacterial infection that's associated with ulcers and gastritis. You might also see diagnostic procedures like an EGD, which helps us visualize part of the upper GI tract. Colonoscopy, we know, to examine the colon. ERCP, this is to assess and treat problems involving the bile ducts and pancreas. CT scans or MRIs, those are more detailed imaging. So as nurses, part of our role is understanding why these tests are being ordered, preparing patients appropriately, monitoring for complications afterwards, and recognizing abnormal results may require follow-up. So the next thing is our clinical judgment. So after gathering our subjective and objective data, we are starting to ask ourselves, what is the most concerning finding? What could be causing these symptoms? Is this patient stable or unstable? What needs immediate intervention? We also continuously analyze changing findings because abdominal conditions can really change quickly. So our reassessments are extremely important. And we're documenting any changes in pain, abdominal distension, bowel sounds, nausea, vomiting, their intake and output, and their response to our interventions. And interprofessional collaboration is another major part of abdominal care. We're going to work closely with providers, radiology, surgery, maybe nutrition, and other healthcare team members. So good communication with them and reporting any changes or concerning findings. And after we've identified the problem, we plan care and implement our interventions, maybe pain management, fluid replacement, NPO status, monitoring labs, and patient education. Maybe we're preparing for procedures or surgery. And then lastly, we're going to evaluate our outcomes. We reassess the patient to determine whether our interventions were effective and whether the patient is improving, worsening, or staying the same. And that was it for today. Thank you so much for joining me on another beautiful journey through assessment, GI assessment. I will see you in class. Can't wait.